MPACT-MI was an extremely informative trial. I thought this was a randomization and empagliflozin or placebo in patients with a recent MI, and the study overall did not meet its primary endpoint. There was no significant reduction in death or heart failure. But if one is willing to go beyond the primary endpoint, as I think is appropriate in this case, there was, in fact, a significant reduction in hospitalization for heart failure and heart failure-related events. It's true looking at first events, total events, adverse events, really a lot of concordance of the data. And some of the data is in the New England Journal of Medicine, some of it was in Circulation, some of it was in JACC. And then some of it is in Lancet Diabetes as part of a comprehensive meta-analysis, the most comprehensive to date, that puts together all the different SGLT2 inhibitor trials and shows, look, pretty much across the board, these drugs reduce heart failure. So I think even though the primary endpoint wasn't met, there really is a positive finding here. Is it clinically actionable? I think it is. So for sure, MPACT-MI established the safety of empagliflozin in this setting of patients with ACS and heart failure or heart failure risk. But I think the meta-analysis corroborates that, well, there are a lot of patients who should be on SGLT2 inhibitors anyway. So the way I would apply it is if a patient comes in with ACS and they're at high risk for heart failure, and even if they're not, if they have diabetes, unless there's a good reason that they should be on an SGLT2 inhibitor, probably barring cost-related issues, they should be. So in that ACS patient coming in, especially high risk for heart failure, but with diabetes, I would put them on an SGLT2 inhibitor because they probably should have been on one anyway, and now we know it's safe to do that. As far as patients without diabetes, if they've got other indications for SGLT2 inhibitors, such as CKD, or in fact have heart failure there as well, I think it's reasonable to use an SGLT2 inhibitor. And I do think the results, even though it was an empagliflozin trial, are generalizable to the class, and our meta-analysis in Lancet Diabetes really corroborates that point. So clinically very useful, I think, but one does have to be a little bit willing to go beyond just primary endpoint p-values. This was a really well-done trial that looked at beta blockers in patients after MI, but with preserved ejection fraction. Do you really need a beta blocker? Lots of different guidelines say beta blockers after ACS, but what if the LV function's preserved? Is there still a benefit? That's been an open question for a while. When we looked at beta blockers in the REACH registry, for example, some years ago, we didn't find clear benefits in the chronic stable patient without LV dysfunction. So I was myself a bit skeptical about whether beta blockers really had benefit in this setting. But that and other sources of data or registries, non-randomized, so you've got to take it all with a grain of salt. Here we have a randomized trial that didn't find additional benefit of beta blockade in the post-MI patient where the LV is preserved. So to me, this is a very important finding that says in these patients, we probably don't need to use beta blockers unless there's some other good reason. I mean, if they had residual angina, atrial fibrillation, if there was some good reason to use it, then of course use it. It's safe. But if there isn't an actual indication, the indication is just, oh, they had an MI, if the left ventricular function looks good, I'd say don't add on another unnecessary medicine. This is really relevant, though, to the patient that's been revascularized. Again, if someone hasn't been revascularized, if they haven't been fully revascularized, if there's residual angina, those are all different situations where beta blockers may still have value. But in an MI, uncomplicated, complete revascularization, normal LV function, I personally haven't always been using beta blockers, and certainly now wouldn't. I think so. I think the results here are really potentially practice-changing, though there are other trials going on looking at beta blockade. So, we should, of course, always keep an open mind, see what the other trials show. That might tweak my answer a bit. But this was really well done trial, and I thought it was practice-changing. This was another great trial presented at ACC-24, comparing a year versus a month of dual antiplatelet therapy And in the month arm, it was followed by ticagrelor monotherapy. And this was ACS patients. People have looked at shorter durations, 3 months, 1 month of DAPT, but in the ACS setting, it wasn't really clear you could get away with it. And here, the results look quite good, less bleeding with the 1 month of DAPT, as one would hope and expect, and as multiple trials have shown. But there didn't seem to be a price to pay in terms of ischemic outcomes. So to me, really reassuring data that a month might be sufficient DAPT if it's followed by potent monotherapy, in this case, ticagrelor 90 BID, though there was an option to go to 60 BID if there was dyspnea or things like that. But basically 90 BID for a year in the monotherapy arm. So some caveats, though, before applying that in practice. These were all patients that were event-free for a month. Obviously, if a patient's not doing well in that first month from an ischemic or chest pain standpoint, you probably aren't going to want to de-escalate to monotherapy. And as well, it was ticagrelor that was studied, with the results applied to clopidogrel, possibly, but, there's always some issues of clopidogrel not being quite as potent as ticagrelor, a little bit more variability in response. So the results, I think, really do just apply to ticagrelor. And though the trial was large and went a year, there's still a possibility that a much larger trial or a longer duration or both might have still found some benefit in carefully selected patients. I mean, there's a lot of data supporting the concept of DAPT. And in some cases, that benefit doesn't really come out till after a year. In the Themis trial, for example, which was not an ACS trial, that was stable patients with diabetes and coronary artery disease. There are the curves that really start to diverge for dual antiplatelet therapy with ticagrelor 60 BID plus aspirin versus aspirin alone till after a year. So, there's still other lines of evidence that do support longer durations of 2 versus 1 agent, the COMPASS trial being another one. Again, not exactly an ACS trial. These were a high risk but chronic stable PAD and CAD. Their vascular dose rivaroxaban 2.5 BID plus low-dose aspirin beat low-dose aspirin alone in terms of efficacy, including lower mortality. So the big unknown, though, is what about ADP receptor agonist monotherapy? So the 2 trials I just mentioned, Themis and COMPASS, and there are other ones, do Pegasus, for example. Yeah, even some subgroups of Charisma, if we go back in time, where dual antiplatelet therapy beats aspirin for long-term therapy. But here, the comparator isn't aspirin. It is, in the case of ultimate DAPT, ticagrelor 90 BID. So whether that's really the sweet spot for antiplatelet therapy, where we de-escalate to ADP receptor antagonists, it seems plausible, because if we look at trials like Capri, where we show clopidogrel was superior to aspirin, especially in some high-risk subgroups, and Host Exam more recently that basically corroborated Capri, but in a post-stent patient, that might be the best of all worlds, where you're balancing ischemic risk and bleeding. So I think we still need to really do more research to figure out the optimal antithrombotic cocktail in patients, despite the wealth of trials. But having said all that, I think in carefully selected patients, this does seem like a viable strategy. In particular, not that the study selected for this specifically, but in particular in patients that are higher bleeding risk, sure seems like you can get away with a month of DAPT, especially if you're de-escalating to ADP receptor antagonist monotherapy. So important results. I think Danger Shock was an extremely important trial, really well done, and answered an important question. There was a lot of controversy out there whether left ventricular support, in this case, a microaxial pump. I'm going to say the brand name, it's the Impella CP. I have to, otherwise it's hard to have the discussion, whether it was really adding benefit or not in the setting of cardiogenic shock or high-risk PCI. Controversy in both settings. Certainly what data exists show a higher rate of vascular complications and other complications, bleeding, etc., than a balloon pump. However, a balloon pump itself, the data have never really been clear, have provided unequivocal benefit in those settings. But the problem is, if one looks at real life, well, you have to throw in a balloon pump when a patient's crashing. You have to put in an Impella if a patient's doing poorly. Which one you pick, it depends on a personal preference and maybe the patient and all sorts of different factors, some scientific, some unscientific. But what we really lacked was great randomized clinical trial data for Impella, and now we've got it in the setting of shock after STEMI. And what it shows is a lower rate of all-cause mortality. So even though it's not a blinded trial, you can't blind these sorts of trials, at least you can't easily blind these sorts of trials, the fact that it's mortality, that's a pretty pure endpoint. Doesn't mean there couldn't have been other things going along with the Impella, other patterns of care that also ended up influencing the outcome. That's always a possibility, in these sorts of trials where there's no blinding. But nonetheless, mortality, very hard to argue with. And it does seem to make sense, at least in my own clinical practice. I've certainly had patients where I felt, rightly or wrongly, but I felt, pretty convinced that the Impella saved their life. And I'm talking about high-risk patients such as STEMI and cardiogenic shock. I've also seen some pretty serious complications, in particular vascular complications and bleeding complications, the occasional stroke as well. So, I felt a randomized clinical trial was necessary. I always felt we should have done one in the U.S. years ago, but I'm glad finally that investigators have stepped up and done this trial, and I think shown pretty clear benefit of the Impella. So to me, this should be a practice corroborating trial, because in the U.S., I think most folks were already doing this, but they were doing it without data, or a device, as I said, that is associated with complications, does have financial costs that are substantial, but with a reduction in all-cause mortality in a patient population where it's really hard to alter mortality, cardiogenic shock, I think this is a big advance. And moving forward, I think in addition to primary PCI and STEMI, that the Impella will have a major role as long as patients don't have contraindications to its placement. That is, no problem with respect to vascular access and an adequate caliber of the femoral arteries, no issue with known left ventricular thrombus. So, things like that would preclude its use. But in patients who are candidates, which I'd say is a majority of patients with STEMI and cardiogenic shock, I had been using Impella, but now I would use it, with pride and joy and a sense that I'm actually doing the right thing and not just rolling the dice, hoping it's the right thing. So great trial. AEGIS-II was a really interesting trial. The results were absolutely scientifically fascinating. The trial didn't meet its overall primary endpoint. Well, the p-value, the safety was demonstrated. We call it a neutral trial overall. Though if we're willing to go beyond just the primary endpoint, as I think we should, and a lot of nuggets of knowledge there, one was that it did appear that this strategy to promote cholesterol efflux, that is taking bad cholesterol out of the plaque, was one that had benefit. So I think the hypothesis has been proven. Has it been proven to the point where we should use this specific drug right now in patients? Well, probably that's not the case, but it does validate the hypothesis that cholesterol efflux is important. If we look at endpoints like MI, it did seem, depends a little bit on exactly when and where one defines it, but there was a real effect in reducing MI, potentially beneficial effects even with respect to cardiovascular death. There was an interesting relationship with the odds of subgroup banalities, an interesting relationship between LDL and the effect of the drug, where as the LDL got higher, above 100 in particular, there seemed to be benefit, whereas as it got lower, there seemed to be less and very little benefit as the LDL got quite low. So that's logical. If there's a bunch of bad cholesterol in the plaque, well, then a strategy to remove it through cholesterol efflux would seem to be more beneficial than if the LDL is really low. So what are the practical implications? Well, I hope there's continued research for this approach of cholesterol efflux. I think there's a lot of promise that was shown in this trial. So hopefully there'll be future therapeutic approaches that try to harness cholesterol efflux. Would there be an advantage over instead just getting the LDL super low? That needs to be examined in future trials. But I think there might be. Event rates obviously are much lower when the LDL is very low, but it doesn't mean there can still be additional benefit. There's still patients coming in with plaque rupture despite having very low LDL cholesterol levels. So low LDL cholesterol is important in reducing atherosclerotic risk, but there are other pathways as well. So it might be that there's a higher dose or a greater dosing interval that's needed, that is more doses of the drug. Here it was IV infusions in a limited number, but perhaps the key to success would have been chronic therapy. Now that would have been tough with this intravenous formulation, but maybe that's what's really needed. So if we had a longer duration of action from something that could be dosed and then stays in the system for really long, or a more frequent dosing, but that allows high levels of activity promoting cholesterol efflux throughout the day, maybe then the trial would have been much more robust in its findings and would have achieved statistical significance. So to me, this opens the door for therapies evaluating cholesterol efflux, and I hope that scientists and physician scientists and industry doesn't give up on this concept.